Beginning?
Wait, should we start?
Yes, it's starting.
Oh, okay, so 7:30. So good morning, everybody. So it is a pleasure today to have Dr. Brian Case from Mr. Heart and Vascular Institute talk about microvascular dysfunction program. As everybody knows, this is actually an upcoming field in interventional cardiology, and I think it's becoming a standard things to do in the cath lab too. So, and as we are starting our program, it's great to have an opportunity to learn from Dr. Case. So Dr. Case, take over.
Yeah, no, absolutely. Thank you so much for the opportunity to present to everyone here and share our experience of starting our CMD program at MedStart, our Heart and Vascular Institute. And I'm excited to hear that your system is rolling out a program. It sounds like you're going to be doing your first case this week, so that's fantastic. Going to spend some time here just getting everyone up to speed, defining coronary microvascular disease and its importance. I'm going to discuss the logistics of doing the evaluation because I think that's a lot of helpful tips and tricks for when you guys are doing your cases up in New York. Going to discuss interpretation and treatment management, and then lastly share our experience at MedStar Health in terms of rolling out a CMD program. So of course, going to always start with a case. This was a 64-year-old female with a past medical history of hypertension who presented for evaluation of chest pain. She had been experiencing weakness and left-sided chest pain that radiated across her chest and up her right side of her neck. No other associated symptoms of shortness of breath, palpitations, or dizziness. And then she reported a few months ago she was also experiencing chest pain while walking too much or lifting heavy objects. She saw her outpatient cardiologist. She was noted to be a little bit hypertensive, some non-specific EKG changes, and a stress test, a nuclear stress test that showed mild ischemia in the apex. As we know, we'd never really know what to do with that, but there was evidence of ischemia. So she got a non-invasive testing, which was the stress test, along with an echo. You can see here that, it's a mild LVH, but normal wall motion abnormalities, normal LV function, and she also had no significant valvular disease. Given the history, though, we felt it was warranted for her to go under an invasive strategy, so she was brought to our lab for a left heart cath. You can definitely appreciate in her left coronary system that her circ and approximate LAD looked fairly normal, no significant disease. Another shot of her LAD here, pretty free of any significant disease epicardially. Her spider shot, nice big left main, nice proximal LAD, nice proximal circ, and a dominant right that is free of any disease as well. So my question for you is, what are you going to do next in 2025? Are you going to stop your case and tell the patient that her symptoms are non-cardiac in nature? Maybe it's GI related and you should go, get an endoscopy evaluation, or is there more that we can do? Obviously, that's what we're going to be discussing today. And, what I really want to take home to everyone that's listening is just your basic angiography is a limitation. You are doing a disservice for your patient if you are just going to do a basic coronary angiography to evaluate their chest pain. There's more to the story. There's more to their symptoms, and hopefully talking about our experience doing this with the CMD program will help your patients up in New York. So how do we define coronary microvascular disease? So if you look at this picture is used at every single CMD talk out there. At the left is a picture of what we see on a basic coronary angiography. These are the large epicardial vessels, your LAD, your circ, your RCA, and the dominant branches. But if you look on the right, you can appreciate that the coronary tree, the circulation within the heart, is much more involved. There is a complex network of prearterioles, arterioles, and capillaries that help regulate the overall blood flow to the heart itself. So when we do an angiography, we're seeing the picture on the left but we're missing all of this on the right. And why is this important? If you look at what controls the overall resistance and flow down the coronary tree, your epicardial vessels only contribute about 5% of the overall flow, versus your prearterioles and your arterioles that contribute about 80% of regulation and distribution of flow, and it tries to match the needs of the local tissue. So you can imagine if you have disease or endothelial dysfunction of these small vessels, that could impair flow to the heart and contribute to the patient to experience angina and or shortness of breath, weakness, fatigue. There's two kind of pathophysiology mechanisms that contribute to coronary microvascular disease. There's structural changes in the microvasculature that results in remodeling. This can be due to buildup of atherosclerotic plaque, focal atherosclerosis within the small vessels, along with intimal thickening. And then you can have functional abnormalities as well. You can have vasoconstriction of the small vessels. We'll talk about the difference between epicardial spasm and microvascular spasm, but you can have spasm of the small vessels, and you can also have impaired relaxation due to the disease endothelial cells that can also contribute to coronary microvascular disease. Again, this is kind of just a snapshot of what contributes to the development of coronary microvascular dysfunction. There's structural changes, functional changes, as we discussed, and also you can have extravascular causes for coronary microvascular dysfunction. You can have increased afterload due to uncontrolled hypertension or, say, aortic stenosis. You get thickening of the LV, and that can cause external compression on the small vessels of the heart, and that can manifest as coronary microvascular dysfunction. In addition, up here, which I haven't mentioned about yet, is it's not uncommon to have microvascular dysfunction after acute coronary syndrome. So somebody presents with a STEMI or NSTEMI, you successfully revascularize the epicardial vessels, but then you get microembolization down to the small vessels, along with reactive particles, and that can result in coronary microvascular dysfunction and or scar. And the patient could have their epicardial vessel be widely patent, but they could still have significant symptoms due to disease in their microvasculature. I love this illustration because this really demonstrates the interplay between coronary microvascular dysfunction and a lot of other cardiac conditions out there. You can almost view coronary microvascular dysfunction as a sequelae of all of these different disease processes, or you can also look at it as kind of like a gateway, such as if you make the diagnosis of CMD, they could just have structural CMD, or it could be an early indication of something else going on in the patient, like an undiagnosed cardiomyopathy, a Takotsubo. We're actually at MedStar Health looking at the role that CMD plays in patients who have had a heart transplant, and seeing if evidence of increased IMR, index of microvascular resistance, could be an early sign of rejection in transplant patients as well. So we're really just at the tip of the iceberg when it comes to fully understanding coronary microvascular dysfunction. Why is this all important? If you take a patient to the cath lab who has ANOCA, angina, and you do a left heart catheterization. Sorry, if you take them to the cath lab and they have angina and you do a left heart cath, 40% of your patients are going to have no epicardial coronary artery disease. We see this all the time in the cath lab. You know, patient has atypical symptoms, a inconclusive stress test. You do the left heart cath, and there's normal coronaries. Why is this important? Because in that cohort, up to 50% of them will have coronary microvascular dysfunction. If you include those patients who might have epicardial spasm or microvascular spasm, that rate actually goes all the way up to 2/3 of patients, of ANOCA patients, are going to have some sort of disease in their microvasculature. So you can imagine the impact that missing this diagnosis can have on a patient. And why is this important? These patients have poor quality of life. They have mistrust with the healthcare system. And then most importantly, which I'll demonstrate in a little bit, they have higher rates of major adverse cardiovascular events going forward. Also, when we look at our ANOCA patients, there is a higher prevalence in women. We see about 2/3 prevalence in women versus men. This has been demonstrated in previous analysis, and that's what we see at MedStar Health in our registry as well. And again, in this analysis, we also demonstrated a higher rate of MACE and a poorer quality of life. So it's more commonly seen in women, but men are affected as well. So your evaluation should occur for both patients. Again, it's often overlooked. If you're not thinking about it or you're not evaluating for it, it's underdiagnosed and therefore undertreated. It results in recurrent angina, poor quality of life, repeat hospitalizations, repeat non-invasive testing, and repeat coronary angiographies. This is our analysis of our patients, about 300 patients from our registry. Patients go undiagnosed for about 2 years, multiple ER visits and hospitalization, multiple days in the hospital, multiple non-invasive testings, multiple left heart cath invasive testings before they get to their final diagnosis. And again, you can imagine the frustration that the patient feels due to this mistrust of the system. You know, they feel their symptoms, they're being told that their symptoms aren't real or their symptoms are being belittled, and it causes a lot of mistrust to the system. There's 2 ways of evaluating for coronary microvascular dysfunction. There's non-invasive, typically done with PET or MRI, and then there's invasive. Non-invasive has been around for a while, and there's a lot of strong data out there. In my opinion, if you're going to do evaluation for coronary microvascular dysfunction, you have to do invasive evaluation. I believe it's more sensitive and specific than the non-invasive modalities. And more importantly, when you perform coronary functional testing invasively, you're able to perform acetylcholine provocative testing, which is important to rule out in these patients, and that cannot be done if you're going to do a non-invasive evaluation. The methods to evaluate invasively, there is 2. There is the Doppler wire looking at flow. Currently in the United States, January 28th, 2025, a Doppler wire is not available. That's probably going to change very soon in the near future, but at this moment, it's not available. The most common system used is the Abbott Corventis CoreFlow system, where it utilizes bolus thermal dilution, which we'll talk about in more detail. And I believe that's what you guys have at your system. So what is coronary functional testing? Coronary functional testing, we're evaluating for coronary microvascular dysfunction, epicardial vasospasm, and microvascular spasm. And we're doing this by acetylcholine provocative testing and then invasive physiology with adenosine. So this is from the ESC guidelines from last year. So the first step for coronary functional testing is you want a washout, meaning if a patient is on a calcium channel blocker or a nitrate, we advise them to hold their medication for 24 hours prior to the procedure to get a good study performed. In addition, what comes up a lot for coronary functional testing is access. Obviously, we know the benefits of doing radial access for our patients and minimizing bleeding complications. The only thing with doing radial access, of course, is we give radial cocktails, verapamil, nicardipine, or a combination with nitroglycerin. And if you're going to be doing coronary functional testing and it's a planned coronary functional testing, I would recommend trying to avoid calcium channel blockers in your cocktail. So for my patients, I try to avoid a radial cocktail, and if I'm going to give something, I'll give nitroglycerin. This is important. That means a lot of CMD coronary functional testing programs out there actually will do all of their cases femoral, just to avoid dealing with the spasm that sometimes patients will experience going radially, especially because, again, 2/3 of your patients are going to be women, and there's a higher incidence of spasm happening in women. So some centers just say, hey, for our coronary functional testings, we're going to go femoral. At MedStar, we still go radial, and we just try to avoid giving the radial cocktail so we get a good study. Then you're going to get your baseline angiography. You're going to rule out any epicardial disease and rule out any intermediate lesion that might be contributing to their angina. Of course, if you're getting referred for coronary functional testing, and this has already been done, you can kind of skip the full baseline angiography and then typically just get 2 views. We usually get a spider view, which helps us for when we're going to wire, and then we do our provocative testing and our invasive physiology in an areocranial that lays out the LAD nicely. Next, at MedStar, we do acetylcholine provocative testing. There are some programs that will switch it. They'll do invasive physiology first with adenosine, and then they'll do acetylcholine provocative testing. At MedStar, we do acetylcholine provocative testing first. We think it makes more sense because in between each dose of acetylcholine, you give nitroglycerin, and then at the end, you give 200 mics of nitroglycerin. And to do a strong, adequate invasive physiology assessment, you have to give nitroglycerin anyway. So it just makes sense to do the acetylcholine testing first, give the 200 in nitro, and then you evaluate for your CFR, IMR, FFR, RFR. So that's kind of the thought process and the workflow at MedStar. It does change a little bit if you do your baseline angiography and you see like a 50% lesion in the LAD. We will switch it in those scenarios. If we see a 50% lesion in the LAD, we want to rule out significant epicardial disease first. So we'll drop our pressure wire down. We'll do an FFR and an RFR for the Abbott system. We'll rule out epicardial disease. We'll do the thermal dilution to look for, to evaluate for CFR, IMR, and then we'll do provocative testing afterwards. So that's kind of our thought process for performing coronary functional testing at MedStar Health. And I'll go into a little bit more tips and tricks going forward. So the first part is doing acetylcholine challenge. What we're looking at here is coronary vasoreactive testing, endothelial dependent vasomotor function. So we're evaluating for epicardial vasospasm along with microvascular spasm. How it works is you give a gradual injection of acetylcholine over a minute through the guide, flushing by hand 5 mLs of saline. These are the doses that we use in the left coronary and in the right coronary. Escalated doses to 100 mics. Some programs will go all the way up to 200 mics. We stay at this level. We typically will evaluate the LAD. There is evidence to demonstrate if you do coronary functional testing of the whole coronary tree, the LAD, the CIRC, and the RCA, your yield of evaluating and finding coronary microvascular disease increases. However, clinically in the real world, that takes a lot of time, a lot of effort. We're busy in the cath lab. So we typically focus our evaluation on the LAD. In addition, if you are going to do evaluation acetylcholine testing in the RCA, there's a higher risk for arrhythmias, and a lot of programs will preemptively put in a TVP prior to doing acetylcholine challenge in the RCA. So of course, that's a lot of work, putting a TVP and changing guides and stuff. So we try to streamline it and just use the LAD. This is our protocol for mixing acetylcholine. I'm not going to go into this in detail, but this protocol is validated. It's used at a lot of CMD programs across the country, and it's what's used for mixing. It sounds like you guys have the acetylcholine protocol up and running, which is great because that can sometimes take a long time. A couple of notes here is once you open the vial and mix it into the saline bag, the shelf life for acetylcholine is about 2 hours. So at my lab, the nurses and the techs know that they pull all the equipment, they pull the acetylcholine, but they don't pop and mix it until we've gotten that baseline angiography and we've confirmed and ruled out epicardial disease. Another kind of tip and trick to do is stacking your coronary functional testing cases. Having a half day or having a full day where you're going to do just full coronary functional testing for the day. That way you could do your first case, mix your acetylcholine, have that bag prepared, and then hopefully you can get 2, maybe even 3 coronary functional testings done using just one bag of acetylcholine. This was helpful because a year ago there was a national shortage of acetylcholine, and we were scrambling and we were trying to save our acetylcholine that we had in stock. So these are kind of just some tips and tricks we do at MedStar Health. So you slowly infuse the acetylcholine, and then you're going to monitor for patient to develop chest pain or ischemic changes. When I do coronary functional testing, I'm kind of light on my sedation because I want to talk to the patient during the full evaluation to see if they're developing chest pain. And if there is, I ask them, hey, is this the chest pain that you've been experiencing recently? Is this similar, the intensity, and so forth? Once you evaluate it for chest pain and ischemic changes, then you're going to do an angiography at each level, 2, 20, and 100. And you're going to be looking for epicardial vasospasm. That is, the epicardial vessels are spasming. And if you want to be textbook, that's going to be a 90% decrease in the caliber of the vessel. And then there's a gray area of about 70% stenosis caliber of the vessel. And then you also want to look for potential slow flow down the vessel as well, which could be evidence of microvascular spasm. Patients, in between each dose, you're going to give nitroglycerin intracoronary, and then you're going to do your next assessment. Patients can get, transiently unstable. You can get, chest pain, hypotension, bundle branch block develops. This all gets better after you give IC nitroglycerin. And I have some examples I'll show in a second. So when I do my cases, I always tell the nurses to have IV fluids hung and ready, atropine in the room, and then I have 10 cc's of nitro sitting right on top of my guide, ready to go to give IC to reverse any spasm that might occur for the patient. And of course, they're going to be on monitors and the Zoll pads and all those other kind of standard things in the cath lab. So this is an example of epicardial spasm. This is a little bit of an extreme example, but I like to show it because you can see just how quickly things reverse. So this is our baseline picture. Again, we like to go areocranial, kind of opens up the circ and shows the LAD nicely here. So this is interesting. At 2 mics and 20 mics, the patient had really 0 symptoms. She had no chest pain, no EKG changes. And then at 100 mics, you can see here that her left coronary system is essentially shut down. I'm not trying to scare you guys. This is an extreme example, but the LAD was occluded and the mid-circ was occluded. Of course, she felt it. She was hypotensive. She was becoming bradycardic, but we quickly gave 200 mics of nitroglycerin over in a minute. This is her repeat angiography here, where the vessel completely came back. She felt better. She was stable. She was discharged home, placed on calcium channel blockers, and she's doing well ever since. The second example I have here is an example of microvascular spasm. Again, this is our baseline angiography, an areocranial view where we're nicely demonstrating the LAD. At 100 mics, she was developing chest pain similar to what she typically feels, along with ischemic EKG changes. And then I do my angiography here. You can see that the lumen is open, meaning it doesn't look like it's spasming, but you can appreciate the extremely slow flow that we're seeing down the LAD. And this is evidence of microvascular spasm. Again, we give 200 IC nitroglycerin, and things open up nicely. Flow is back to normal. She feels better, and she was placed on calcium channel blockers and has been doing well ever since. So how do we interpret acetylcholine challenge as a whole? Chest pain and or ischemic EKG changes during acetylcholine infusion without epicardial vasospasm. You're dealing with microvascular spasm. Chest pain, ischemic EKG changes, and luminal narrowing. Certainly 90%, sometimes 70%, that's coronary vasospasm. So that's acetylcholine provocative testing. And then you want to move on to your endothelial independent testing. So you want to do your invasive physiology to evaluate for coronary microvascular dysfunction. And what we're doing is we're looking at different physiological indices to evaluate the microvasculature. And if you want to do a good job evaluating for CMD with your invasive physiology strategy, you need to know the basics of doing physiology and understanding the different indices. The system will give you all of this information. They're going to give you an FFR, which we all know is the gold standard hyperemic indice for epicardial disease. It's going to give you an RFR, which is a non-hyperemic indice looking for significant epicardial disease. It's going to give you a coronary flow reserve. Coronary flow reserve is the flow from the beginning of the coronary tree to the end. Impairment or abnormality in your coronary flow can be due to either epicardial disease or microvascular disease. And impairment of your index of microvascular resistance, if this is elevated, then that's going to be what's contributing to an abnormal coronary flow reserve. So this is what we're doing in the cath lab. We're trying to get these indices to evaluate to see if somebody has coronary microvascular dysfunction. Real briefly, again, there is a Doppler tip wire that measures flow down the vessel. This is being done or used in Europe. Currently, in January 2025, we do not have a wire available in the United States, but that's going to change very, very soon. I'll leave it at that. And we're very excited to get that technology and evaluate it in our cath lab. But this is certainly what most centers are using. They are using the Abbott Pressure X wire. This is our standard physiology wire. But what's interesting is they have a temperature sensor tip at the end, which allows for a bolus thermal dilution technique to be performed, where we can measure transient time at rest and in hyperemia, and that allows us to calculate a CFR and an IMR. So this is a quick video demonstrating kind of the ergonomics of how we do in the lab. Guide, your wire, your physiology wire is down the LAD. Ideally, you want that physiology wire at least 2/3 down the LAD. Three-way stopcock. This is our reservoir of saline. We usually a 20 cc syringe. And then this is what we're going to be injecting down the guide. It's the 3 cc syringe. In our lab, it's like a gold medallion. My lab knows that if we're going to do CMD, they automatically get three-way stopcock, the syringe, and the gold medallion. So we fill up 3 cc's here, make sure there's no air, and then you quickly inject it into the guide, and then the system will measure the transient time, and then you reload, and you do it again like this. So this came out in JSky last year, and it's a mnemonic just to help you remember the different steps for doing CMD evaluation. The C, this is just good invasive physiology techniques. You want your guide well engaged and coaxial. You want to flush out all the contrast, and you want to ensure there's no dampening. Then you want to advance your pressure wire down the LAD, at least 2/3 down it. And then you want to give nitroglycerin, and of course, before advancing your wire, ensure that you have leveled and zeroed. Then you want to do your injections, transient time at rest. Then you start adenosine. You get the patient hyperemic, and then you do your bolus transient times as second time. And then the core flow system will calculate a CFR and an IMR, and then you can make your final diagnosis. Coronary flow reserve. What's normal? All intents and purposes, we believe 2.5 is normal. So anything less than 2.5 would be abnormal. And then index of microvascular resistance, we consider normal less than 25. So anything above 25 would be abnormal and would be a sign for concerns for increased resistance in your microvasculature. This is what the core flow system looks like. To the right here, this is our waveforms. To the right here is your epicardial indices, so your FFR and your RFR. These are your transient times down here at rest and then hyperemia. This is like what your transient times actually look like. Your goal is to try to get these numbers as close as possible, at least 0.15 difference. Just like how you do with a right heart cath, you want these numbers consistent. You can always click on a box and delete it and do another injection. And then you're going to start adenosine, get them hyperemic, and then do your injections in hyperemia. And then the system will output a CFR and an IMR here. Again, what's normal? High CFR above 2.5 and an IMR less than 25, and no evidence of epicardial disease. That is normal. Low CFR, so less than 2.5, and an IMR that's elevated, and normal epicardial vessels, that's structural CMD. If you go in and there's a 50% lesion and you see that your CFR is low, but then your IMR is normal, and you have an abnormal FFR or RFR, maybe that 50% lesion isn't 50% and it's actually ischemically significant. One interesting thing that we see a lot, and we sometimes struggle to deal with, how to deal with it, is when we see the CFR is low, so the patient has impaired flow, but their IMR is normal. This is something we call functional CMD. We're kind of learning more and more about it, but a lot of times we see it in patients who are in a high output state. So if they're like, if they had a fever, yes, that would contribute to it. But like if they have anemia or they have hyperthyroidism, that can kind of cause this pattern. I've actually diagnosed hyperthyroidism once in my lab because it was a young patient. She had this finding. I said, hey, why don't you check some TFTs with your primary care doctor? And she ended up having hyperthyroidism. So this is just the breakdown kind of treatment algorithm for doing coronary functional testing. You're going to do acetylcholine provocative testing to look for endothelial dependent abnormalities, and then you're going to do your invasive strategy for physiology to look for endothelial independent microvascular disease. These are the kind of the bucket diagnoses that we can make for our patients. But what I want to emphasize is patients can have more than one thing going on. They can have epicardial vasospasm and CMD, or they can have an overlap more commonly of microvascular spasm and CMD. So I always get asked the question, is it important to do both parts of coronary functional testing? And yes, absolutely, it is important. Is it safe? Does it take a long time? How much extra contrast are you using or radiation? It's quick. If your lab gets proficient, you can do it in 5 minutes. We looked at our data. We compared doing coronary functional testing to just doing a basic left heart cath, and we noted that it just resulted on average 10 more mLs of contrast, only about 2 more minutes of fluoroscopy time, no statistically significant difference in terms of radiation dose, and the overall procedure time was about 2.5 more minutes. So once you get efficient doing coronary functional testing, you can do it quickly, and you're not going to hold up your lab for 2 hours doing this whole complex evaluation. We were excited last year in 2024, ESC guidelines, the updated guidelines gave class 1 indication for doing coronary functional testing in ANOCA and INOCA patients. The American guidelines are from 2021. They gave it a 2A recommendation, but I do suspect with this ongoing push and evidence that this will probably become a class 1 indication in the US as well. The next couple of slides just demonstrate what we know, that patients with coronary microvascular dysfunction have significantly higher clinical events. It's shown that patients who have decreased CFR have increased clinical events, and then specifically patients with low CFR, high IMR our structural CMD patients have increased major adverse cardiovascular events up to 5 years. Post-PCI patients, if you have a beautiful PCI to the proximate LAD, but your patient has residual increase in their IMR, they're an increased risk for MACE up to 5 years after the procedure. And then also your post-MI patients. If a patient comes in with a STEMI, you get a door to balloon time of 22 minutes, and you get a beautiful result. But then their IMR leaving the cath lab is above 40. They have a higher risk for adverse events going forward. So this is a beautiful review by Bruce Samuels and other co-authors that was published in JACC in 2023 that I really recommend your group read. It talks about a lot of what I just spoke about, doing a full coronary functional testing, again, about the tips and tricks I talked about, and then kind of the bucket list of diagnoses that we evaluate for patients. How do we treat patients for CMD? I'll talk briefly about this. We know from the landmark Core-MICA trial from Dr. Tom Ford and co-investigators that doing coronary functional testing has dramatic impact on our patients. It improves their quality of life 2 ways. One, it gives them a diagnosis. They get validation in their symptoms. You know, they're not crazy. They have real chest pain, and we can identify specifically what that chest pain is. The second important thing is doing a full coronary functional testing. You pinpoint exactly what's causing their symptoms. Is it coronary microvascular dysfunction? Is it epicardial vasospasm? Is it microvascular spasm? Is it a mixture of all three? And that's important because you are going to tailor the therapy specifically to what is going on. Yes, a lot of the time it's going to be calcium channel blockers, beta blockers, or nitrates, but a lot of times we'll pull one medication versus another based on their type, their endotype. And this is the second part to that JACC review. And you can see these are all the different treatment options that we have for our patients. There's a lot of different treatment options out there. And a lot of times it's a trial by error for your patients. Once you have a CMD patient, you have a CMD patient for life, and you might have to use, 1, 2, 3, 4 different therapies to treat your patient. Sometimes if I'm really struggling with a patient and we can't get them on a good therapy, I'll even show them this paper and show them this picture and say like, hey, this is what we've tried so far. Now we're going to move on to this other pharmacology therapy and see if this has any impact for you as well. So this is a very useful tool to have in your center and also to share with your patients. And then ESC also has some guidelines that are very similar to that review. One other thing to note for all your ANOCA patients with coronary microvascular dysfunction, you're always going to recommend the same things, which are proper diet and exercise, weight loss, smoking cessation, and then controlling other modifiable risk factors such as hypertension, hyperlipidemia, and diabetes. And then even sometimes I try to get patients into cardiac rehab. Sometimes there's issues with insurance, but if you can get patients into cardiac rehab, they do well with their symptoms also. All right, so for the last 10 minutes, I want to just talk about how to start a CMD program and really discuss our experience at MedStar. So we got CoreFlow installed in 2021, August 2021. We quickly started doing, CMD evaluation. A little bit of a hiccup getting acetylcholine up and running at our center. Just working with pharmacy and getting them on board. It sounds like you guys are already have pharmacy on board and have your acetylcholine protocol. That's fantastic. And really strong work by you guys. We've done about 350 cases within our system, and we're the only program in the Mid-Atlantic region that's a coronary functional testing center. So we do get a lot of referrals, a lot of challenging cases, and we welcome them for sure. Recommendations for kickstarting the program at your hospital. Of course, first and foremost, you want a leader or a champion in the cath lab to roll out the program. You want somebody who has the foundation of understanding of doing a proper and full, accurate, correct, invasive physiological testing. In addition, there's a lot of good resources for that person. We have a microvascular network group chat on WhatsApp where we, present cases, ask for patients' recommendations, thought leaders' recommendations for our patients. So it's very helpful, and I definitely recommend anyone who's interested in doing corneal functional testing to join the Microvascular Network. We also have a CMD forum where we have a meeting once a month. We actually had it last night where people speak about their experience and we present cases and we just share our knowledge and talk about what's working and not working at our centers. And then lastly, Abbott has a lot of educational programs that you can get a part of to really get up to speed and become an expert to performing corneal functional testing. You want to have a good relationship with your advanced cardiovascular imaging folks, and then also with a non-invasive cardiologist for follow-up. Advanced cardiovascular imaging is important for two reasons. One, if you have PET, which I'm sure you do, you can evaluate for coronary microvascular dysfunction using PET, and then you can do those patients can be referred to your program to do full coronary functional testing to look for both endothelial dependent and independent dysfunction. In addition, we all know that MINOCA, myocardial infarction with non-obstructive coronary artery, the workup for that involves both evaluation with with cardiac MRI, but then also with doing coronary microvascular dysfunction. So if you have a MINOCA patient, you're going to recommend a cardiac MRI, and if they're continuing to having symptoms, you want to know about these patients, hold on to these patients, and bring them back as an outpatient to do coronary microvascular dysfunction. The non-invasive cardiologist part is important. Again, once you have a CMD patient, you have a CMD patient for life. They get attached to your hospital and your system in a good way. They're extremely grateful that they have a diagnosis, and they're going to follow up with you. They're going to follow up, and it's going to take some time to, increase the dose of their medication or alter their medication or try a different medication. And that takes some time with outpatient follow-up. Of course, you're going to want a strong partnership with Abbott to set up the system in your lab, which it sounds like you guys already have done. And then also they're going to be key to help with getting the word out in your community. Work with pharmacy to get acetylcholine in your lab and create a protocol. This could take time, but do know that there are protocols out there. Utilize those already established protocols. Present to the pharmacy department, make them aware why we're doing this, and they'll get on board fairly quickly. The last thing, which I think is key, is get buy-in from your staff. When you start to do coronary functional testing, they're going to look at you like you have two heads. Like, why are you injecting this medication down the coronary and causing spasm and hypotension and ischemic changes? And then they're going to look at you crazy, like, why are you wiring this completely normal LAD and doing all these crazy injections with the thermal dilution method? If you sit down and educate your staff and make them aware of why you're performing coronary functional testing, they will get on board. I promise you that. And once you have your staff on board, they're going to help to streamline your procedure. When we do coronary functional testing, like a planned procedure, my team rolls out. They have everything ready. They have the adenosine ready. They have the acetylcholine, ready to go if there's normal coronaries, and they have all the extra equipment that's needed to perform the thermal dilution technique. And then, which I love, is if you do a left heart cath for whatever reason and the coronaries are normal, your team will challenge you and say, hey, why aren't you going to do coronary functional testing on this patient? And then they love it. They love to see the patient get their diagnosis and the positive impact that we can have on patients. So get the buy-in for your staff for sure. How to increase your referral program. We started internal first. We did in-service and grand rounds within our cardiology department and then the medicine department. And then we did in-services and grand rounds with the other hospitals within our system and then our neighboring hospitals within our region to get the word out. Then second, we worked with Abbott and we did dinner symposiums with all the private cardiology practices in our region. So they were made aware that this technology was available, and you'll see it every time. you'll get a call the next day from one of the outpatient cardiologists. They'll say, hey, I've had Mrs. Smith in my practice for 5 years. We've done 9 stress tests and 4 left heart caths, and we can never figure out her chest pain. Can you please evaluate her for coronary microvascular dysfunction? It happens every time. We all have these patients in our practice, and now we have this technology to fully evaluate our patients. We also reached out to internal medicine doctors and OB/GYN physicians. Internal medicine physicians were actually pretty beneficial because a lot of times they'll have a patient who has chest pain. They go to a cardiologist. The cardiologist does a full evaluation. The evaluation was negative. They get, kicked back to their internal medicine doctor, but they're still having chest pain. And we tell them, hey, bring them to us. We'll evaluate them. OB/GYN physicians were helpful because, again, 2/3 of the time you're going to be dealing with a woman. And younger women, a lot of times they use their OB/GYN doctor almost as like their primary care doctor. And a lot of times they'll have like shortness of breath and fatigue. And those OB/GYN doctors will send them our way to evaluate them for coronary microvascular dysfunction. And then lastly, you want to get the overall awareness in your community. There's a lot of patients out there who are struggling with INOCA. And again, they feel mistrust with the system and the healthcare system in general. And they are struggling and they're suffering and they're looking for answers. And if they understand that this is out there, they're going to be willing to come see you, even if it's 2-3 hours away. So this is what we did at MedStar. We had pamphlets that were sent out to the community. Myself, you all know Dr. Haider Hashem and Dr. Itzik Bendor were the 3 that do it at MedStar Health. And it just describes what coronary functional testing is and what coronary microvascular dysfunction is, and just saying, hey, we can help you. Come see us. We'll evaluate your chest pain fully. We also did webinars. This was on Facebook Live. It was a women's heart health discussion, and I got on board to talk about coronary microvascular dysfunction. And then Dr. Hashem did a couple of news breakouts. This patient was one of the first patients we did. It was actually a live case at CRT, and then she told her story on the news, and Dr. Hashem was interviewed as well, and that really got the word out as well. So you get the word out in your community so patients are aware that this is available. Lastly, when you start your program, you're going to do a lot of ad hoc procedures. What do we mean by ad hoc? A patient comes in just for a left heart cath. You do the left heart cath. It's normal. And then you tack on coronary functional testing at the end. This is fine. This is a good way for you to get used to doing the procedure, your staff to get used to doing the procedure. It's beneficial for your patients. And then after you've done it, you can go back to the referring physician and say, hey, we've just got this new system in our cath lab. I decided to do it on your patient because her symptoms were really bothering her. And we found that she has coronary microvascular dysfunction. I'm happy to tell you this, and we can treat her appropriately with beta blockers. And just want to let you know that we have this system in our lab. Of course, the more and more ad hocs you do, you get the word out. You're going to shift more from ad hocs to planned procedures where patients are specifically coming for coronary functional testing. And the more planned procedures you do see a nice increase in positive cases, confirmed cases, as you get more kind of referred coronary functional testing for you. And again, it's important to get the word out that you have this technology, both with your colleagues, your referring cardiologists, and also the general community. There's now ICD codes for coronary microvascular dysfunction. This is a push by Dr. Haider Hashem in the Microvascular Network. This is great because I think this will help with reimbursements going forward. And then also ICD codes will help with ongoing research using national databases to further evaluate these patients. And then lastly, a plug. We do have a registry. It's the Coronary Microvascular Disease Registry. It's a MedStar-led registry. It's the PIs are myself and Dr. Hashem with senior mentorship from Dr. Ron Waxman. We have 4 sites currently involved in CMDR, with 5 more sites actively getting the documentation done to be involved as well. It's an international registry. We're following patients both prospectively and retrospectively. We have about 350 patients in our registry at this moment. It's free of charge to participate, and we certainly welcome your healthcare system to join our registry once you get up and running fully. So going back to our patient, she had normal coronaries, no acetylcholine provocative testing demonstrated any epicardial disease or microvascular spasm. So we did a coronary microvascular evaluation with thermobolus technique, and you can see that her epicardial vessels were normal, FFR was normal, and RFR was normal. And then we did a CMD evaluation here, and you can see that it was markedly abnormal. Her CFR was 1.1, so it was low. So her coronary flow reserve was compromised. And then her index of microvascular resistance, her IMR, was significantly elevated at 37. So she was diagnosed with coronary microvascular dysfunction. She was started on a beta blocker and has done well ever since. And she was extremely grateful for us to make the formal diagnosis for her. One other case, and then I'll have some time for questions. This is a 75-year-old woman, hyperlipidemia, GERD, actually had an NSTEMI in the past with a PCI to OM in 2018, ongoing symptoms of angina, had a repeat left heart cath in 2019, which showed patent stent, no other disease. They had another left heart cath in 2020, which showed a intermediate lesion of 50% in the LAD. They even did physiology at that time with FFR, which was negative. She was started on medication, long-acting nitrates, but she was not tolerating them well, and she was really debilitated by her angina. So she came to us for a second evaluation. This was her left heart cath, right dominant RCA, no disease. This is her OM, which demonstrates a Wiley patent stent. This was her LAD, where you can argue there's about a 40-50% intermediate lesion. So we dropped our pressure wire down. We performed epicardial indices first RFR, which is our non-hyperemic indice, which was negative at 0.93. And then we did our hyperemic indice FFR, which was negative as well. And then we did our CMD evaluation, and you can see her CFR was borderline low, but her IMR was significantly elevated at 39. So even though she had Wiley patent stent and no epicardial disease, her microvasculature was impaired. She was optimized on calcium channel blockers and has done well ever since. So I want to thank everyone for the opportunity to present how we perform coronary functional testing, some tips and tricks, and then how we kind of rolled out our program at MedStar Health. Want to give a quick shameless plug to CRT 2025. It will be in Washington, D.C., as it always is, March 8th to March 11th. And on Saturday, March 8th, we actually have a full CMD program lined up, and certainly welcome anybody interested to attend. Have a lot of great speakers lined up, and we actually are going to have a live case as well. So thank you, everyone, for the opportunity. And certainly I welcome any questions that anyone would have about what I've spoken about today.
Thank you very much for your great and comprehensive talk. I obviously have a lot of technical questions, but I actually want to give it to my colleague first. Andrea, do you have any question?
Hi, Brian. First of all, thank you so much.
Yeah.
It was really a great talk, and I agree with you. In an academic institution, especially, this is really a must-have tool. We should offer this to all our patients. I have a question for you. It's actually an interest I have. In your experience, of course, you did. Have you repeated this testing on a patient who was on therapy after you diagnosed microvascular dysfunction? And did this confirm or make you change the therapy you gave to the patient the first time?
Yeah, no, this is a great question. We're actually exploring at MedStar Health, looking at our post-MI patients who have elevated IMR and being aggressive with therapy, and then bringing them back and seeing if their IMR decrease after therapy. And then also for our CMD patients, if they ever end up in the lab again, we certainly will repeat the invasive physiology to see what the IMR is. And certainly it makes sense if you put them on a therapy and you bring them back and their IMR is still elevated, it questions if the therapy is actually being effective for the patient. There is a lot of interest of doing this in a randomized controlled fashion. Of course, you have to get an IRB approved, and there's a lot of risk with that because you're repeating invasive physiology and dropping a wire down the vessel. But intuitively, it makes sense that if your IMR is still elevated after therapy, then maybe that therapy is ineffective and you need to try a different one. So yeah, absolutely. The other thing that we're looking at now also is, coronary sinus reducer, right? Initially, that was looked at for chronic angina with mixed results, but it's being now evaluated in a randomized controlled fashion for coronary microvascular patients. And that's 100% one of the indices they're looking at. They're looking at a change of the IMR pre and post therapy, and that is an indication that the therapy was effective.
Excellent. Thank you.
Yep.
Anybody else?
Hi, good morning.
Hey, good morning. How are you?
Good, good. Thank you for this fantastic talk. As you know, we will be starting our program soon. So if you want to increase your referral base with PCPs and with general cardiologists, who would you say, who would you recommend to be the ideal patient they send your prototype patient to kickstart your program and hopefully have some positive results?
Yeah, no, great question. So I think it really depends on the type of specialty you're talking to. I think if you're talking to your cardiology colleagues, I think you want to really target those patients that have been having ongoing symptoms for a long time and nobody can find an answer. We've all had these patients where they've had, multiple coronary CTs, a left heart cath, MRI, multiple stress tests. They are convinced they have symptoms and nobody can give them the right answer. They've gone to 4 or 5 cardiologists. I think those are the ones you really want to focus on first with your cardiology colleagues. And then the only other thing for your cardiology colleagues is you can mention that a lot of patients who have had abnormal stress tests in the past that have had normal coronaries, a lot of them might have coronary microvascular dysfunction. That was demonstrated in a beautiful JACC article from last year that there was a high prevalence of CMD in those patients. The cardiologist will kind of second think those patients and say, hey, maybe something else is going on. Maybe, it would be beneficial for you to undergo a repeat left heart cath to look for these symptoms. And then for internal medicine doctors, keep it more broad, just say like, hey, any patient that's having chest pain, even if they're young and they don't have a lot of risk factors, like bring them our way. Like let us figure out what's going on and let us help them. Let us do the work. Kind of keep it more broad for those folks. And then we've found some benefit with the OBGYN community as well, in terms of younger women who kind of use their OBGYN doctor as like their primary care doctor. That's been helpful.
Perfect. Thank you. That was very helpful.
Yep. Looks like we have another question from Andrea.
Yes. Hi. Good morning. Thank you very much. Great talk. I really learned a lot. Actually, 2 questions. The first one is just your experience with STEMI patients, if any. I mean, the prognostic implication of MVD in this population of patient acute coronary syndrome seems to be striking. And so wanted to know if there's any experience from your centers and if you see these being routinely done, if in the future, if we can have the technology to actually being able to pinpoint patients that are actually going to be at risk of IMR after epicardial revascularization. And the second question is more of a general question, is in regard to whether or not there's any evidence that MVD is actually has a spectrum of disease versus binary. Whether are there patients that have more severe MVD, and is there a way that we can correlate that?
Yeah, no, two fantastic questions. First and foremost, no doubt about it, we know that increased IMR post-STEMI patients have evidence of worse outcomes, higher rate of scar development, and then, of course, higher rates of ventricular arrhythmias, and then, more importantly, development of heart failure. And 1 out of 5 STEMI patients anterior STEMI patients will develop heart failure at 1 year. And, we've done a great job with our door-to-balloon times and, open that infarct vessel right away. But even though we're opening that infarct vessel, the damage is being done distally to the microvasculature, and that's contributing to that scar to be created. So there's a lot of interest in minimizing the development of scar and preventing coronary microvascular dysfunction in STEMI patients. The evidence is mixed. There's been a lot of different medications trialed and cooling and other things, and all intents and purposes has been negative trials. There's now other things being looked at. That two things that come to mind is unloading the ventricle. Like, of course, we have the door to unload trial right now, and there's interest to see how that's going to impact scar development and also coronary microvascular dysfunction. And then secondly, there is a FDA-approved modality out there, supersaturated oxygen, and there has been some case reports of an anterior STEMI coming in, physiology being performed with an elevated IMR, and then giving supersaturated oxygen, and then IMR decreasing significantly after that's being administered. We have done it ad hoc a few times, and we've noticed a difference. But certainly there needs to be much more, true randomized controlled clinical trials in this space to A, document feasibility, B, document change in the IMR from these therapies, and then lastly, showing long-term outcomes of developing these type of therapies. So a lot of interest in that particular field, and a lot more to come, in my opinion. And then your second question, comment, 100%. This is not binary. It's not one bucket CMD versus microvascular spasm. There is a spectrum. There's a lot of overlap, and then also there is different levels of severity. I don't know if we're biased, but at MedStar Health, we do feel like the higher the IMR, the more the symptoms. Like, there is a rough correlation. Again, that's not validated in any study, but we do appreciate that an IMR of 50, those patients are really impacted versus an IMR of 27. But certainly it's a spectrum, and it's not one diagnosis for your patient. There's a lot of heterogeneity in this patient population.
Thank you.
Yeah.
I think we don't have much time, but I also have a couple of questions, and I have tens of questions, but let me pick 2. But so it's interesting. So this microvascular dysfunction, it's really not only the ANOCA, a typical chest pain patient. It looks like there's a lot of use for other field too. So once I'm sure in the beginning we'll just do all this, chest pain, persistent chest pain patient. But once you establish your practice, your practice right now, do you do a lot of most of the patients are this typical women with a lot of chest pain, or do you also do that post-MI patient, or say post-transplant patient, and those more expanded indication? And that's one question. And the other one is actually related to this, but I was going to ask if you do a lot of patients without, not that typical chest pain patient, but we also have a lot of post-heart transplant population here. And I started picking up all this surveillance angiogram now. And of course, I started reading about IMR study. But wondering if for surveillance, you bring the patient back and you want to do intravascular imaging too. And do you do intravascular imaging and IMR for this? It's started becoming a big project for the surveillance angiogram.
Yeah, no, great question for both. For the first question, at this point, if I have a patient that's coming in with any symptoms of chest pain or shortness of breath, and their angiography is normal, I'm performing coronary functional testing, because you are just surprised how many times you find it. Of course, when we first started, it was your typical patient who had been evaluated a lot of times and came specifically for you. But at this point, we are doing coronary functional testing on most of our normal angiographies or insignificant in coronary disease angiographies. So that's either going to be planned or ad hoc, like I was talking about before. The only times we're not doing it is if the vessels are not really amenable to drop a pressure wire. So that's like if there's an anomalous takeoff of the LAD, or the LAD is like super calcified, or more importantly, super tortuous, and it's just too high risk to drop the pressure wire down. We're avoiding in those patients. And yeah, we are looking at it in like Takotsubo patients. We're always doing IMR evaluation now. We're doing a lot in hypertrophic cardiomyopathy patients, and we're finding value in a lot more patients. So the blanket statement would be we're doing it for most of our patients, just because we're always finding something. The post-transplant population is of high interest of ours. Is as we all know, it's a very delicate population. You have to work very closely with your advanced heart failure colleagues. They're very precious, those patients. Initially, there was a little bit of concern of giving IV adenosine to post-transplant patients who are at risk of arrhythmias. But we were, after a little bit of discussion, we're able to get our heart failure patients on board, our heart failure physicians on board for our patients. And do we do it at every heart transplant patient at the moment? No, but we have done a series, and we've found nice results. We always do IVUS for surveillance for our patients to look for CAV. So typically we'll do IVUS first, look for CAV, and then use the pressure wire to do IMR assessment. Of course, we don't do acetylcholine provocative testing on those patients. It's just the IMR. But it's another area that we're just understanding the surface, and a lot more research needs to be performed on that field. And there's a lot of opportunity for doing research at your center to look at these patients. But you definitely need a buy-in from your heart failure colleagues.
Yeah, what referring actually is interested. So we are actually discussing about it, but trying to decide how much we want to do.
Yeah.
And then one last question from our colleague. So does a sluggish flow on coronary angiogram, this actually have any predictive value on microvascular dysfunction?
Yeah, so the short answer is no. There's a lot of data out there, a really good trial last year that was presented, published in JACC, that you cannot just rely on sluggish flow to rule in or rule out CMD. There's no correlation. So you need to do a full coronary functional testing to make the correct diagnosis, and then again, the correct endotype for the patient, so you can tailor the therapy correctly for that patient.
Okay, I think it's 40. Thank you very much. It was great. It was especially we are starting our first case tomorrow, so this was very helpful to start up our case too.
Yeah, absolutely, and we're always available, always happy to run cases with you guys.